you for the invitation. I'd like to thank the organizing committee. It's very nice seeing you, Professor and Professor Popescu. I apologize for not being there. Unfortunately, something changed the last time. I'll try to keep it brief. We'll talk in the next few minutes about the CMR, but about the myocardial viability, but from the CMR perspective. Dr. Karabinos was very comprehensive and said a lot of things about viability and the challenges of today. So I will keep it short. We spoke about living cells, which means viability, and as far as clinical perspective is concerned, we're discussing about dysfunctional myocardium that may potentially recover after revascularization. This was shown by Elias previously. This showed that probably viability may matter. We see here that patients with viable myocardium, when they were revascularized, they had a better survival comparing to those with medical treatment. And from among the patients that were revascularized, those with viable myocardium had better survival comparing with those with non-viable. The STITCH trial, Elias spoke about that, spoke about the criticism regarding the non-randomized sub-study, and this was an observational sub-study. There was no CMR in this study. The definition of viability, especially on SPECT, was debatable, and the results caused some concern regarding the value of viability. The studies that look in viability have some issues we need to keep in mind when we read the studies. The lack of standardization, each technique is an issue. How long we wait until we evaluate the revascularization. Some studies focus on 3 or 6 months, but we have seen improvement even after 40 months. There's a big question regarding the functional improvement as a gold standard, as a standard of success of revascularization. There have been studies showing that maybe the improvement of patient is not, it doesn't equal from the ventricular systolic function improvement, but maybe an issue, a thing of symptoms improvement, functional class improvement, arrhythmia burden improvement. So moving on to CMR, which I will focus from now on. This is a pie chart of the studies done in UK, and we can already see that the viability studies represent 23% of referrals, and along with ischemia, which they usually be done together, they represent 42% of CMR referrals in United Kingdom. The three pillars of assessment when we do viability assessment in cardiac MRI is anatomic information regarding wall thickness, contractile reserve, as we'll talk about that a little bit later, and most of the times the extent of the infarct with a late gadolinium enhancement. Regarding wall thickness, most of the studies and the clinical experience have a cutoff of 5.5 millimeters that has a sensitivity of 94% to pick up, but a specificity, a low specificity, 52% to predict functional recovery. And this is because thinning can come due to severe prolonged ischemia and not only scar. This is a very interesting study looking on more than 1,000 CMR studies that showed that almost 1 out of 5, 20% of patients with thin segments in the cardiac MRI had less than 50% scar in the late gadolinium enhancement sequences. And this group of patients improved after revascularization. So we need to bear in mind that thin myocardium doesn't mean necessarily a scar. And that's the thin myocardium also is an issue with nuclear techniques due to the lower spatial resolution on these methods. The main asset we use in cardiac MRI is gadolinium enhancement. Gadolinium is a large element that doesn't cross the healthy membrane of the cardiomyocyte. However, when there is damage, then it can be accumulated either in the damaged cell or in the extracellular space, and with a delayed washout. Thus, we can see that in sequences taken 10 or 12 minutes after injection to see the injury. And the injury, as we know, has different patterns, and the typical pattern of the ischemic injury is coming from the endocardium and having a transmularity of even 100%. So, as we can see in this case, in the right image, for example, we have most of the myocardium being a transmular infarct of 100%, but we can see on the lateral wall a thin line of late gadolinium enhancement with a epicardial rim of probably living cells without injury. And we can see, as we said, the transmular infarct, like this case with a small apical thrombus. We can see that most of the anterior wall and apex is 100% late gadolinium enhanced. However, due to the high spatial resolution of cardiac MRI, the technique is able to detect very, very small mass of injury, like small embolic infarcts or very small subendocardial infarcts, like this case that we can see here. And this exactly measure the extent of the gadolinium in enhancement of the wall thickness is the one that we use in cardiac MRI to predict the likelihood of recovery as a continuum more than just the binary determination of viable or not viable. This is the first study that all started with patients undergoing revascularization, and they showed that 90% of patients with extent of LGE more than 50 did not improve. It's not so predictable what happens to the patients having less than 50%. So the percentages here are 60 to 80. And this study also showed and put this thought in our minds that maybe finding a small epicardial viable rim in patients with even more than 50% of extent of the infarct that may not recover as far as systolic function is concerned could mean a benefit of these patients comparing to those having a complete 100% scar. These results were confirmed in later studies like this one, and confirmed again the negative predictive value of this technique to detect myocardium that won't probably recover as function is concerned. A short break with a case. This is a 67 years old man who presented with a newly diagnosed heart failure and shortness of breath that deteriorated over time. He had this quite severe systolic dysfunction and had an angiogram that showed 3 vessel disease, and he had a cardiac MRI scan to assess viability. And this was the result, which is quite astonishing. We can see a quite extended but thin line of injury in the endocardium in a lot of segments without, but a huge amount of living cells. So we can say that probably this patient will improve after revascularization. This meta-analysis confirmed again that the 50% cutoff had a high sensitivity to pick up patients that won't recover, but a very low specificity again. And they suggested that in patients with less than 50% of injury, maybe a contractile reserve study like the dobutamine MRI could help us decide on those patients. In practice, though, the dobutamine cardiac MRI is not something that happens often, and what we usually do in those patients is ischemia and viability study in a protocol of 30, where we can assess anatomic features like wall motion, normality, and thickness, perfusion with the use of adenosine or adenosine, and the infarct. So by combining all information, we can have the ischemia and viability information we need. In real life, this is a very nice study made by Chiara and her team. They investigated 50 patients with CTO and picked up those to revascularize based on the CMR results, looking on perfusion defect, both defect and myocardial and infarct on the LGE. And they did a second scan 3 months later. What they found out is that indeed the perfusion was improved in those patients in the CTO territory after the revascularization, and the function was improved, showing that cardiac MRI was able to identify those patients that would benefit, and the CTO could indeed reduce ischemic burden and improve quality of life. One, of course, needs to know the limitations of each technique. One is the availability. Another limitation is the devices, not because they're not compatible with MRI. We now in some centers scan even non-MRI compatible devices, but because of the artifacts that sometimes may interfere with in the interpretation and made that quite tricky. And of course, severe renal impairment. I'm finishing with 2 slides to keep it brief. This is a recent study published by Imperial College London, where they looked into the scar characteristics, the infarct characteristics, and they identified peri-infarct zone and infarct core, and they associated these characteristics with the sudden cardiac death. So this could be something in the future, looking into the image characteristics of the injury. And also, this is where also AI comes into the game. And that's another work in progress. This is some new sequences of dark blood LGE sequences, where comparing to the bright blood that we can see and we currently use on the top, it's worse resolution, but very high contrast. And with these sequences, we can detect even very small rims of infarct that we could miss due to the brightness of the blood pool on the top. So I'm concluding, cardiac MRI has a very high spatial resolution. It's able to detect even small non-transmural infarcts, embolic infarcts, and based on the transmularity as the main way to assess, we decide on the likelihood to recover as a continuum rather than dichotomizing viable to viability, viable to non-viable, sorry. It has a very high negative predictive value. So those that have more than 50 or even more than 75 in some studies, probably the function won't be improved, but it's less predictable in less than 50%. Can be used in patients with that's gonna go to a very complicated, expensive, and high-risk procedure like a CTO in a high-risk patient. So it could be used to help us decide on that. Not use it as a one-off to deprive a patient from treatment, but to be sure if we want to have a high-risk patient go a complex procedure. And in the end of the day, as Professor Nihoyannopoulos taught us, there's not a gold standard. He and me also doesn't like this term. In the end of the day, we will choose the technique that we're more confident with, and the technique that we know that will help us decide, and also taking into account patient characteristics and the limitation of each method. Thank you very much.
Thank you very much, Dr. Loizos. I think it was a very good presentation. I think we should move forward with the next one. If I may ask Petros to invite the next speaker.